Welcome. We're hosting here a small session on artificial intelligence. My name's David Deaton. I'm the moderator, and I'm going to pass the microphone to our panel. Where you think artificial intelligence will make the biggest impact in the field that we're in, vascular care?
Thank you, David. Well, I think the biggest impact is going to be in our ability to analyze patient data to an exponentially greater degree than we're able to do right now, and that has to do with progression of disease, outcomes following procedures, and also remote monitoring. I think a lot of this came out in the session, which was really fantastic, and I suspect that it'll be even more interesting next year when we see what the further developments are.
Stefan?
Well, Dave, I was awarded recently a 7.5 million grant by the French government to develop AI solutions to help us as aortic surgeons in our everyday practice. So what we're working on is first AI to help us with this very time-consuming task of looking at CT images every day and trying to figure out if an aneurysm sac or a dissection is growing or shrinking, looking at diameters, looking at volumes, and this will probably change our algorithm and the way we follow those patients. We're also working in AI solutions to size appropriately the endograft, including complex endograft, and also to simulate. Sometimes you don't know if you need a fenestrated or branch endograft. Well, just simulate it. Sometimes you have a short angulated neck. Simulate various endografts that are available on the market and see which one will adapt better to that anatomy. So a lot to come.
Dave, I can echo what Stefan and everyone else has said, but really I think what's going to help us is we're going to move vascular imaging into vascular surgery departments because we won't need the radiologist to do any detailed reading. So the vascular component will be read by an AI. It will tell us what the diagnosis is, and we'll get much more accurate readings much quicker, and it'll help our efficiency and our patient care.
So the next question I have for the group, and I want to make sure you can hear me, is that we see artificial intelligence being used to personalize things so that it can react to whatever you are. Do you think there's going to be a role for artificial intelligence to identify patients who are either sick or about to be sick before they even know it by going through medical records or other things, so that we can call patients, instead of them calling us, we would call them and say, you're at high risk for this and you should be evaluated. What's your opinion on that?
I think that's a great question. I think it's absolutely true. I think it's starting to happen right now a little bit. There's a number of different programs, commercial and in-house proprietary, where that's being done. Scanning through our own database, particularly of CAT scan images, identifying patients who might be at risk, have growth. I mean, the first great step is the ability to do it in large numbers and even simply to call patients who aren't coming back for follow-up. And then the next step from that is to identify high-risk patients. But I think you could expand that eventually to monitoring patients with bypass procedures, peripherally, stents, angioplasties, and the like.
Stefan?
So coming back to AI in imaging, in our PACS system, we have thousands and thousands of CT scans. AI will look at all those CT scans, look for carotid disease, look for aortic disease, look for SFA disease, and then we can actually get in touch with the patient and see if there's any symptoms associated with those diseases. So it's exactly what you were quoting. It's going to go the other way around. We are going to contact the patient. And on top of that, we now have AI system that will go into the patient file and tell us which patient are at risk of having major issues after surgery. Looking at the EGFR, for example, that will actually ring a bell before you actually realize that something is going on. So obviously, it's going to change the way we perform surgery in the coming years.
Yeah, so the other thing, Dave, I would say is that we need to make sure the data integrity is good, because wrong data can get us to some wrong answers, and we're trying to predict this stuff. It's a big issue. But I think AI will team up with the electronic health record and stuff that you and I wouldn't think is a factor. Oh, they're on some medication. It will be able to go through millions of records and find some little small uptick that's causing a problem that we would never have looked at in research. And I think that's where the power of the data is going to come, but the data's got to be accurate.
I'll make one other comment. In the U.S., you really don't get access to health care until you have a clinical problem. It seems to me that we may be able to identify patients who are going to have a problem earlier and actually do preventive medicine. We talk about doing preventive medicine, but our system is not set up to do that and to start impacting the progression of that. whatever process it is, you mentioned the EGFR, before they come for dialysis, or before, if we see a lot of vascular disease, say you need to come in for a medical evaluation, you put on an exercise program, whatever. My final question to the panel is, everything that gets invented has sort of a good side and a bad side. So I think there's a lot of angst around artificial intelligence, certainly in the press there is. And even the heads of the major technology companies have not developed it because they're so worried about that. What do you see as a potential risk using artificial intelligence in medical care or vascular care?
Well, I think to echo Dr. Farber's point, you have to be sure that the integrity of the data that's going in is sound. That's number one. And number two, we know that certain large memory bank and AI models have the tendency to what they call hallucinate. So we have to have checks and balances in place with the clinicians to be sure that that's not happening and that we're keeping an eye on it so that the further developments don't get off the rails, so to speak.
So artificial intelligence is artificial. It's there to help physician, not to replace physician. So I think what we have to make sure that we can spot outliers. So if the imaging system is analyzed automatically and comes up with a 40 millimeter or a 70 millimeter for an aneurysm, we need to make sure that it's accurate. So we need to have a way to control what's going on. So at the end of the day, the current software that we have will be very accurate in 90% of patients. So we have a way to scroll through the aorta that has been analyzed by the aorta in by the AI software in a couple of seconds, and see if the AI system did a good job. So we need to still be in full control of what's going on, because otherwise we'll have major issues.
Integrity.
Exactly, data integrity.
I think the other thing, Dave, is we'll find associations. Associations don't mean causality. And we have to make sure we don't make that leap of faith from an association to a causal problem, because they're not always 100% related. So we have to be careful about making that mistake. That's the problem with using AI and just blatantly following what the association is.
What do you think the next phase for AI is? Where do you think it'll be applied in the next 5 years, the next 10 years, I guess?
That's a hard guess. I think that, first of all the things that Stefan and Mark talked about is going to be applied to. But one area I think that would be interesting for us, there's a lot of debate around what to do for patients with asymptomatic carotid disease. And I think the tendency has been to push more and more to non-operative intervention, medical management of those patients. But I think using AI to look at plaque morphology and predict which patients may or may not have a vulnerable plaque that might become symptomatic. I would like to see that happen, so we'll see if it does.
I think, Dave, one of the major issues is going to be the cost associated with those solutions. What's the added cost and what's the benefits?
Return on investment.
Exactly. So we need to figure this out before our hospital director decide to invest. And exactly, because this will be obviously a game changer. But when, this will depend on the economic model.
I also think, Dave, we got a shortage of healthcare providers at all levels. And I think AI can maybe be used to help us with that. It will also, as Stefan said, potentially help us reduce cost. And that's where I think we're going to be headed with this, because we can't continue on the same path we have been the last 20 or 30 years.
How do you see our industry partners using AI? And do you think there are any watch-outs?
That's a good question, but I'm sure they're going to use it to the same degree as us. And to Stefan's point, I think that they may have better resources, at least at the outset, to use that. So I think they're going to be looking at. I think they're going to look at performance. I think they're going to look at physician performance. They're going to look at their own device performance, and they'll use it for their own predictive models.
Yeah, in Europe currently, we need to run post-market studies. If you do a post-market study, the cost associated with a core lab looking at OCT images is huge. If you can have an AI system that replaces, then suddenly those industry partners will be really happy and will provide the data that is expected from the notified bodies. On the other hand, I think that the interesting part for the industry is maybe they will provide to their physician, for example, the endograft companies will provide us with solution to help us in our everyday practice to look at images and design endografts. So there are many ways the industry can actually benefit from AI.
Yeah, I think the iterative process that AI will do will actually may help us not have to do too many post-market. We'll be able to model what's going to happen and find out we didn't predict that in the modeling and then iteratively do it help. And that's, I think, the benefit of it from an industry perspective.
Well, as we know, a lot of the accuracy of artificial intelligence, machine learning, deep learning, and by the way, I'm not a computer scientist, so I may be mixing these terms up, but requires a large amount of data, right? It's what, do we need new mechanisms of cooperative data sharing, between institutions or countries, to power AI? Do you think that will happen?
Well, I think it would be ideal. I think if you look at our own U.S. experience with incorporating interoperability into our own programs, and that's been a bit of a struggle, I think that's going to be a financial question. But ideally, yes, we'd have integration across institutions, countries, with data sharing.
Stefan, particularly for you in the EU, I think a greater ability to do that than in the US. Do you see that happening now?
Yes, and it's mandatory because we're developing those AI solutions with single center data sets, but then we need to validate those solutions. And to validate those, you need as much data as possible. So we need a country database access, and obviously multi-centric data is mandatory. So we need to make this happen.
Yeah, David, it'll help for sure in terms of the pure numbers, but we do have to be careful about data manipulation. If Stefan is working in kilograms and we're working in pounds, and someone does a conversion and we have a problem with that conversion, then it may mess up the whole data analysis. So we have to be careful. The databases should all be uniform and how we report and everything, and it is sometimes a problem doing that, but that would be the goal.
Yeah, I think we'll have to develop different mechanisms. I think we're about at the end of our time, so I'm going to pass the microphone around, but I'm going to start by congratulating Dr. Veith and all of the Veith staff for, I've been coming to this meeting since the 1970s. My father was a surgeon, so I came as a child, but it's an event every year. It's the 50th anniversary, so a hearty congratulations.
I would echo that. Congratulations, Frank, and all the staff. I think I'm almost at 30 years, so I don't have you beat, and thank you, David, and everybody. It was a great session.
Well, thank you, Frank, for the incredible dedication provided to the vascular community over those last 50 years. It's always great to be back in New York. I always learn amazing things, and I'll be back next year.
Thanks again for a great meeting, Frank. We enjoyed coming up here and allowing us to all get together. It's a lot better than doing it over the video like we did during COVID. So thank you.